Good afternoon. I'm sure that you guys are thrilled that we finally got to the meat of the conference. So I wanted to thank Dr. Sabella for inviting me back. This is actually one of the best review courses in the country. It has like 120% passing rate, 60% the first year, 60% the second year. So without further ado, we're going to talk about respiratory disease in newborn. At the end of the presentation, you'll be able to recognize respiratory distress as a symptom associated with both respiratory and non-respiratory etiologies, review the common respiratory diseases that cause respiratory distress in newborns, itemize associated prenatal and perinatal risk factors, and describe their pathophysiology, clinical, radiographic features, and treatments, and hopefully you'll pass the boards. So I only have 120 slides, so I'm going to try to go a little fast here. But the important thing is that, and you guys are mostly pediatricians or maybe some subspecialists in the audience, when you get called to evaluate a newborn with respiratory distress, obviously you think lungs. You have to actually broaden your spectrum a little bit. Respiratory diseases oftentimes present with respiratory distress, and respiratory stress is actually one of the most common causes for admission to the neonatal ICU, with TTN or transient tachypnea of the newborn being one of the most prevalent diagnoses that we see, and infection in the way of sepsis and pneumonia are followed behind. People have this misconception that we spend most of our time taking care of preemies, and actually that is not the case. I mean, they spend a long time in the NICU, but we spend most of our time taking care of these babies, the bigger kids. And in recent years, obviously, the what now is called the late preterm occupies a lot of our time and occupies a lot of our beds in our NICUs. The problem with respiratory distress is that there are multiple etiologies, and not only respiratory disorders can lead to respiratory distress, not only respiratory diseases can lead to respiratory distress, but there are a number of non-respiratory causes that actually can present with respiratory distress and fool you. So the list goes on. In my mind, when I see some of these babies, the first thing you want to do is to rule out the things that can actually kill a baby. And cardiovascular disease is really at the top of the list. Most of the times, we call it because the baby is desaturated a little bit, it's a little tachypnic, maybe a little blue. And so cardiovascular disease, is the first thing that a neonatologist tries to rule out, because oftentimes it may become an emergency and you don't have a whole lot of time to think about it. But there are a number of other systems that can actually present or present themselves as a respiratory distress syndrome, and you have to think about those as well. Hematological causes, for example, kids with polycythemia can present with respiratory distress and cyanosis. Kids with severe neonatal anemia can present in the same way. Obviously, infectious diseases we talked about, and Dr. Sabella will go extensively into that. Metabolic disorders is one of the less common disorders, but when you have a baby in the newborn nursery who crashes on day 1, 2, 3, you have to think cardiac, infectious, metabolic. If you think that way, you're going to be right most of the times. There are other less common disorders, musculoskeletal, neurological, central nervous system, and peripheral nervous system, and neuromuscular disease that may present in the newborn period with primarily respiratory distress in the first few days of life. And a good example of that is a baby who is born to a mom with myasthenia gravis. The baby goes to the normal newborn nursery, and a few hours later they call you because the baby has ptosis, is not feeding, and started to have apneic spells. You get a maternal history, mom had myasthenia, and myasthenia gravis in babies usually present in about 15%, 20% of newborns born to these moms, and they usually are fine at birth, but then they tend to decompensate in the first 24 hours of life. Occasionally they may go home. If you're in those places where babies go home after a few hours and moms have a drive-by delivery, and they may get sick at home. So obviously the history is very important in those cases. And occasionally you'll have the kid with the unusual neuromuscular disease in the form of myotonic dystrophy or spinal muscular atrophy. In terms of respiratory diseases causing respiratory distress, just for didactic purposes, people have divided this into parenchymal conditions, developmental abnormalities, mechanical abnormalities, and airway abnormalities. Amongst the parenchymal conditions, the most common diagnosis usually we deal with, and I was told that neonatology was only 5 diagnoses, and these are it. Transient tachypnea of the newborn, respiratory distress syndrome, pneumonia, Meconium Aspiration syndrome, and pulmonary hypertension. Very quickly I learned that there aren't 5 diagnoses, there are only 6. So developmental abnormalities, congenital diaphragmatic hernia, congenital cystic adenoma malformation, or CPAM. This used to be called CCAM, and now they made this terminology change to encompass most of the conditions you will see in terms of malformation of the airway and the parenchyma of the lung. Pulmonary sequestration, TA fistulas, pulmonary hypoplasia, infantile lobar hyperinflation, formerly called infantile lobar emphysema. Obviously, we won't be able to touch on all of this, but we're going to try to at least touch upon some of them. There are other causes also that may present in a more period that are completely out of the order for a pediatrician, but actually these are the things that we see the most in the first 24 hours of life in babies who may present and get admitted to the NICU for respiratory distress. And pulmonary air leaks in the form of pneumothorax and pneumomediastinum are extremely common. Actually, if you walk through the NICU, let's take that back. If you walk through the nursery, actually 10% of the newborns in the newborn nursery will have a spontaneous pneumothorax. You just don't know about it because you don't x-ray every baby. But 1% of them will become symptomatic. And oftentimes are underdiagnosed because we don't do x-rays on everybody because they tend to get better very quickly. We think, transient tachypnea, and so we don't get a film. But when I was a resident, and that was just about 5 years ago, we used to x-ray a lot of these babies, and there are some beautiful papers, showing the data to be accurate. Airway abnormalities also are rare, but when they present in a newborn nursery, they could be very challenging. And airway obstruction could be primarily intrinsic or extrinsic. They present with stridor, and remember, when a baby has inspiratory stridor, the obstruction is extrinsic. When they present with extrinsic respiratory, with extrinsic stridor, the obstruction is intrinsic. So you cannot forget that. If you learn one thing tonight, that's it. All right? Otherwise, get your money back. So I'm just going to warm you up. We're not going to do a whole lot of questions to embarrass anybody, but this is one of my favorite questions because if you have to learn 2 things, this is the other one. And it's nice to see that I do not recognize anybody this year. So obviously people from next year, they all pass the boards. And that tells me that the other half from the year before also passed the boards. So what are the lungs of the fetus filled with during intrauterine life? The options are meconium, surfactant, amniotic fluid, protein-rich fluid, none of the above. If I didn't go to medical school. I always wondered if there was somebody who didn't go to med school here. I was doing the endocrine questions. I flunked miserably. So I would have been F on this slide. So 3, amniotic fluid. Let me tell you something. I know med school is really expensive in this country. You should go back and get at least 50% of your money back. So if you choose amniotic fluid, don't worry, you're not alone, but you're still wrong. Okay? The lungs of the fetus are filled with fetal lung fluid. And there's a huge difference between amniotic fluid and fetal lung fluid. Babies do not have any amniotic fluid in their lungs. That would be extremely abnormal. But they do have lung fluid, which is actually a fluid that is made in the lung. is rich in chloride and potassium, is poor in protein, and is actually actively secreted. And lung fluid is important because it promotes lung growth and also facilitates in babies the growth of some endocrine factors that will eventually allow the baby to establish a functional residual capacity at the end of gestation. Some of it drains into the amniotic fluid, and this is where the confusion comes in, and it represents about 1/3 of the amniotic fluid volume. So far you've learned 3 things tonight. So that's absolutely more than I ever wanted to give you. So physiologically, when the baby is going to be born, if they know they're going to be born because the mom starts laboring, the lung fluid production decreases, and nitric oxide, surfactant, and beta-adrenergic agonists decrease lung fluid secretion. This is, again, another misconception that we were all told in medical school. Uterine contractions play an insignificant role in lung fluid clearance. So this idea that babies born without labor have retained lung fluid is not because the uterus is not contracting, it's because the baby did not know that he was going to be born. So he kept making lung fluid. So clearly there's a connotation as to what happens when you have a lot of lung fluid in your lungs at birth. And also there's a connotation when there is not enough lung fluid in your lungs when you're going to be born. So this is an X-ray of somebody who clearly didn't have a whole lot of lung fluid, so the lungs didn't grow. So these X-ray findings are most likely associated with what? Jones asphyxiating thoracic dystrophy, Potter's sequence, polyhydramnios, Potter's sequence, I wish I was at the beach, Potter's sequence, or pulmonary hyperplasia. So what's the correct answer? Should we do this again? All right. The correct answer is Potter's sequence, in case you didn't notice. So basically you had a baby who has all kinds of air leaks, a chest that is really, really tiny. That baby did not have a lot of lung fluid, did not have a lot of amniotic fluid, and that is a restriction of lung growth because of lack of space. Dr. Potter was a pathologist and described this syndrome in 1946. And I'm pretty sure she'll be dead again if after all the hints that I gave you and you got her wrong. But it's okay. So decreased lung fluid formation will promote pulmonary hypoplasia, abnormal pulmonary architecture, abnormal lung mechanical properties, which will lead to this type of presentation in the newborn period. Now, we have a term male newborn who is delivered by repeat C-section with the ruptured membranes at delivery. Apgars are 9 at 1 minute and 9 at 5 minutes. At 15 minutes of life, the infant is noted to have tachypnea and minor intercostal retractions. He's acyanotic with peripheral oxygen saturations of 88 to 90 on room air. There is no cardiac murmur, just radiograph shows expansion of the lungs to 8 to 10 anterior ribs, perihilar streaking and fluid density in the right horizontal fissure. Of the following, the best therapy for this infant is intravenous furosemide, intravenous ampicillin gentamicin, tracheal intubation surfactant, intravenous PGE1, or supplemental oxygen by hood. Vindication. All right. So in today's environment, we would actually use a nasal cannula, but this is primarily what you need to do. Just give these babies a little bit of oxygen and let them reabsorb their retained lung fluid. I just want to mention something. This is a typical X-ray for a baby with TTN. However, you notice that the baby is intubated. And TTN actually is a retrospective diagnosis. You can't make the diagnosis of TTN from the get-go. These babies can get really, really sick. In 1990 through 1994, these babies represented 14 to 15%, 16% of the kids that we put on ECMO. and extracorporeal membrane oxygenation. So TTN may not be such a benign pathology after all. Transient A in the newborn is the most common cause of respiratory distress in newborns, term and preterm. Results from delayed clearance of fetal lung fluid. It presents with obviously the typical signs of respiratory distress, GFR, granting fluid retractions, tachypnea, plus minus cyanosis. These baby stats were in the 80s and low 90s, and just I want you to remember, it's very difficult to tell when a newborn is cyanotic. So you have to get a pulse ox. You can't really rely upon your clinical skills, no matter how good they are, because it's very difficult for the naked eye to recognize hypoxemia. It resolves usually between 48 and 72 hours, usually benign, self-limiting, and the risk factors are C-section delivery without labor, late preterm delivery, maternal diabetes, precipitous delivery, and prenatal depression. The chest x-rays basically just show you the lung volumes are usually good, increased interstitial markings that are retained lung fluid that tends to escape the lungs through the lymphatics, the venous system, and primarily through reabsorption because of the inhibition of the apical sodium pump in the respiratory epithelium. Mildly hypoxemic, plus minus hypercarbic, oftentimes hypocarbic because they tend to breathe really, really fast. Oftentimes they match the heart rate. They can breathe 100, 120 times a minute, even more. And the differential diagnosis is very complex, and that's why you cannot make this diagnosis prospectively. You can't just look at an X-ray and say, oh, this is TTN, and I'll show you some cases where it looked like TTN, but actually turned out to be something else. So always a retrospective diagnosis. When I moved to a smaller baby, 1600 grammer, born at 32 weeks, pregnancy was complicated by preterm labor and precipitous delivery. Mother received no antenatal steroids, and her membranes ruptured just prior to delivery. At 1 to 2 hours of age, the infant develops tachypnea, grunting, nasal flaring, and subcostal retractions. Of the following, the most likely radiographic finding in this infant would be A, B, C, D, or E. You can read them so we can save some time. Fabulous. So 88% got it right, which is a nice compliment to the audience. Fine retrogranular pattern, air bronchograms. This is a typical description of what it used to be called hyaline membrane disease, and now we know that that is primarily surfactant deficiency. This is a typical film of a preemie baby with a fine retrogranular pattern, very hazy, bilateral symmetric, air bronchograms bilaterally, and you can appreciate an endotracheal tube on this patient. It's the most cause of severe respiratory distress in the newborn. Basically, what this is a lack of surfactant in a somewhat immature lung. This is the most typical scenario that you'll see in a premature baby. Actually, just for those who like Jeopardy and get to go there someday and make a lot of money, JFK's baby actually had respiratory distress syndrome at 34 weeks gestation. That baby would have never died today because basically would have given him surfactant and the baby would have been just fine. And actually the death of Patrick Kennedy was actually what stimulated the research of this condition. And independent two investigators described that this disease was secondary to surfactant deficiency. It took about 40 years before the first synthetic surfactant was used in a preemie baby, and that was about 1987 or so. And Patrick died in 1956, I believe. So the incidence of this disorder is inversely proportional to gestational age. The younger you are, the more likely you are to become surfactant deficient if you are born below 32 weeks gestation. However, some full-term babies may have this disease, particularly those born to infants of diabetic mothers who have a high insulin level because of their high glucose. Insulin actually is a nice growth factor in the baby, but unfortunately, what happens is also delays lung maturation. So the hyperglycemia in the mom promotes hyperglycemia in the fetus. The fetus has a beautiful response with insulin, and insulin delays lung maturation by about 2 weeks. So you can have a full-term baby born to a diabetic mother, and the baby will have rip-roaring respiratory distress syndrome. Surfactant is a beautiful protein. We all have it in our lungs. Very nicely to have a lot of it when you're a newborn. When you're an adult, like most of us, we have very little surfactant, but that's plenty to maintain our lungs open. When you're a newborn, newborns have about 10 times the concentration of surfactant that any of us would have if I took a volunteer and mince your lungs and measure the surfactant. You'd be very upset about getting your lungs minced, but that's a different story. So what happens is in the newborn period, babies need a lot of surfactant because it takes a lot of surfactant to open up lungs that are filled with fluid or lungs that are atelectatic. And the recycling of surfactant happens very quickly. So they use up about 100 milligrams per kilogram of surfactant in the first few breaths. And very quickly a newborn can become surfactant deficient. Preterm babies, on the other hand, they have as much surfactant as any of us in this room in their lungs, but that's not enough to open up their lungs and establish a functional residual capacity. It's a beautiful protein and phospholipid combination. Phosphatidylcholine is the main phospholipid, and that accounts for most of the physiological properties of surfactant. Importantly, in recent years, about 15, 20 years, people have elucidated the importance of the protein, especially protein B and protein C, which are essential for survival, especially protein B. Protein SPA is an immunomodulator, and the deficiency of it in humans has not been described, but in animals, if you don't have SPA or SPD, which is not on this slide, there's a tendency to have more infections, and it's almost like a lung immunodeficiency. Babies with RDS present at birth. It's just that they may not become symptomatic for a few minutes, but the disease starts at birth with all the typical symptoms that we mentioned, and they tend to get worse before they get better. And before they get better, they tend to urinate a lot. They improve their cardiac output, they get rid of the extra fluid. Most of the fluid that is already in their lungs as well gets eliminated through the vascular system into the urine. So there is a nice correlation between recovery and the brisk diuresis. We've changed all of this now by giving babies surfactant that comes in a bottle. So if you take a baby like this, you give them surfactant, these babies are in room air, extubated, doing fine in just a matter of hours. So importantly, these babies actually, the management has been simplified tremendously, and is mostly supportive with obviously respiratory support, oxygen, and the mortality has decreased significantly over the last 20 years. Question 5, and you should be able to answer this because I already mentioned the answer. So the treatment of RDS with exogenous administration of surfactant is most likely to decrease the incidence of IVH, bronchopulmonary dysplasia, pulmonary hemorrhage, retinopathy prematurity, mortality, and pneumothorax. Beautiful. So a little bit of confusion, but I think I find it interesting that a lot of you actually thought like a lot of us when surfactant became available, because everybody thought that surfactant was going to put us out of business by basically wiping out bronchopulmonary dysplasia. Unfortunately, that didn't happen. Actually, we have more bronchopulmonary dysplasia now than before. But what it does do is decrease the mortality rate and the incidence of pneumothoraces. So if we had the Kennedy's baby in one of our NICUs, or any NICU for that matter today, that baby would survive with just a dose of surfactant or 2. So it has not made an impact on bronchopulmonary dysplasia. It was one of the big disappointments, but nonetheless, surfactant replacement therapy is one of the most important advances in medicine, in pediatrics over the last 20 years. And actually, when you look at infant mortality in this country, this intervention plus antenatal steroids are the 2 medical interventions that are credited with decreasing infant mortality the most in the US. Just so you know, in many, many countries, surfactant is not available, and babies continue to die from respiratory distress syndrome. There are some preventative strategies. Obviously, if you want to prevent respiratory distress syndrome, you have to prevent prematurity. Short of that, we can give moms a couple of doses of corticosteroids. Corticosteroids stimulate fetal maturation, not just the lungs, but also the brain, the heart, the intestine, and skin. Not free of complications. We still see a significant number of babies who develop pneumothoraces. The numbers are much smaller than that these days, probably in the range of 2 to 9%, depending on which mode of ventilation they need. And some of these babies, especially the very preemie ones, 23, 24 week gestation babies, may still develop significant bronchopulmonary dysplasia, formerly known as chronic lung disease. So, a pregnant mom is counseled to have a repeat C-section as her pregnancy approaches term, to avoid delivering a newborn who has immature lungs and consequent respiratory distress syndrome. She undergoes antenatal assessment of her amniotic fluid. Of the following, the amniotic fluid test most likely to predict fetal lung maturity is phosphatidylglycerol, alpha-fetoprotein, surfactant protein A, thyroxine, sphingomyelin. Beautiful. About 2/3 of the population got it right. PG is actually the marker that if you have PG in your amniotic fluid when you're about 34 weeks gestation, chances of a baby having respiratory distress syndrome are less than 1%. On the other hand, the LS ratio, which is something that most people are familiar with, has a lot of pitfalls. If there's blood, it's going to be useless. If there's meconium, it's going to be useless. PG has the advantage of not being altered by blood or meconium in amniotic fluid. It's very easy to do. There are quick tests that you can do, and the reproducibility of the test is much, much better than the LS ratio. The people who chose 5E, lecithin, sphingomyelin, actually, sphingomyelin is just a marker to correct for the volume of amniotic fluid, and you use that for your LS ratio. So sphingomyelin is just a correction factor. So before delivery of an infant at 41 weeks gestation, the obstetrician remarks that the amniotic fluid contains thick particulate meconium. As the infant is placed upon the warmer after delivery, he appears limp and pale with absent respiratory efforts. Of the following, the most important initial step in resuscitation of the infant is to determine the infant's Apgar score, initiate tracheal intubation with suctioning, provide positive pressure ventilation, suction the hypopharynx, and aspirate the gastric contents. All right, so no confusion here. I mean, basically, it's just that, things change very quickly in neonatology. So 44% of you would have been correct about a couple of years ago. Today, 40% of you are correct. And the reason for that is that the American Academy and ALCOR and every other organization that deals with newborn resuscitation, NRP, so on and so forth, heart, lung, and so on and so forth, the guidelines changed, and they published those guidelines this year. So there is, for those of you attending deliveries, two things. We have to educate still some obstetricians who love to use the bulb. They see a head come out, and they remember there was some meconium, and they just go at the baby like there is no tomorrow. That they want to suck up, I don't know what they want to suck up out of the baby. What they're doing basically is delaying the delivery of the kid. Suctioning the mouth and the nose at the perineum is absolutely worthless. So when you go to delivery and your obstetrician is doing that, you just tell them, next time you call me to come to delivery, don't do that. That's old story. That has been proven to be worthless. We used to do that all the time. Some of us even tried some meconium because we used to actually suck meconium at the perineum with the so-called the Lee suction bulb or suction trap. And when the trap got filled with meconium, you were basically aspirating meconium yourself, which was not really nice. So what you need to do is basically grab the kid and proceed with endotracheal intubation and positive pressure ventilation. So that's the most current approach to managing these babies in the delivery room. So no suction of the nose or the mouth by the obstetrician. You grab the kid, you don't waste any time suctioning. You just, if the baby has all these symptoms, you go ahead and tube the kid and give the baby positive pressure ventilation. All right? Alrighty. Newborn whose estimated gestational age is 42 plus is stained with meconium. Tracheal intubation reveals meconium below the vocal cords. The infant has respiratory distress. A chest radiograph is obtained. Of the following, the most likely radiographic finding is decreased lung volumes, coarse, patchy infiltrates, pleural effusion, reticulogranular pattern, mediastinal shift. Beautiful. Okay, so we're waking up. That's good. So, coarse patchy infiltrates, no question about it. This is an X-ray that most of you have seen. It's a typical X-ray of acute meconium aspiration syndrome. You can see the heterogeneous patchy infiltrates. These X-rays actually do come up on boards occasionally with this history. It should not be a difficult question to answer. This is your typical scenario. This baby could actually be in room air, believe it or not. There is a significant clinical radiological dissociation in meconium aspiration, in meconium aspiration or meconium stained fluid. You can have a kid with darker lungs, not as much infiltrates, and that kid could be really, really sick going on ECMO. Unlike RDS, where there is a bad X-ray, there is a bad baby. In meconium, there may be a bad X-ray and a good baby, or a good X-ray and a bad baby. So this is very important to distinguish from other conditions. Depending on who you read, 10 to 15 of all deliveries are meconium stained. Usually they call the pediatrician or the neonatologist to attend. Most of the time these kids are born and they're absolutely fine. You don't have to touch them. The incidence of meconium aspiration syndrome with respiratory distress is really low, thank God. A lot lower now that obstetricians are delivering earlier. Those moms who come in at 41 weeks and they're not doing anything. We used to see this a lot in post-term babies. I mean, this was typical disease of the post-term kid. The mortality significantly lower these days, maybe less than 2%. Kids who end up on ECMO, who are rare, they have over 95% survival rate. And those kids used to have an 80% mortality rate. So with the advent of surfactant, high-frequency ventilation, nitric oxide, and other therapies, we're not doing ECMO anymore for these babies. It's extremely rare that these babies get to be so sick anymore. Some kids actually pass meconium because they get a little stressed out. If they don't breathe, things are going to be fine. The more asphyxiated the baby is, usually they pass meconium and then they start breathing. And when they start breathing, then you're done because the meconium is already in the small airway. And that's why it's not really suggested anymore to try to suction babies and delay resuscitation because the aspiration already happened. That's why you have to start resuscitating them very quickly. As I mentioned before, post-date fetal distress, hydrohypoxia, those are the typical risk factors. And the management, as I mentioned, high-frequency ventilation, oxygen, INO, surfactant, and of course, antibiotics. We give antibiotics to everybody, to the chagrin of Dr. Sabella. There are some ways of preventing this, but really the baby who is being asphyxiated is really the amnion infusion doesn't do much. The amnion infusion may help the obstetrician feel a little bit better because they dilute some of the meconium. The most important thing is to know that if there is fetal distress and meconium, that baby needs to be born, really. Amnion infusions just delay the inevitable, which is the baby needs to be born. Pathophysiology, not that complicated. One-way valve, a ball valve phenomenon. Air goes in, doesn't come out. These babies tend to have hyperinflation. Other areas of the lung, they are really obstructed. So you have VQ mismatch. They get hypoxemic. Hypoxemia begets more hypoxemia, vasoconstriction of the lungs, and the really horrible persistent pulmonary hypertension that most of the times is what these babies get the biggest complication from, and some of them may end up on ECMO, although these days with nitric oxide, that's a lot less common. So, 3-hour-old infant deliver a term, respiratory distress, Clinical history, significant meconium aspiration, meconium stained fluid. Chest X-ray shows bilateral diffuse course infiltrates. The infant is receiving mechanical ventilation with FiO2 of 1 or 100% and a high mean airway pressure. Arterial blood gas reveals a PaO2 of 35 millimeters of mercury. Echocardiogram shows normal anatomy, flattened intraventricular septum, right to left shunt at the ductal level, and significant tricuspid regurgitation of 4 meters per second. All of these things are consistent with significant persistence of pulmonary hypertension. Of the following, the most specific therapeutic intervention to treat this problem is hyperventilation, sodium bicarbonate, dopamine infusion, inhaled nitric oxide, surfactant replacement. You guys are amazing. I should take a selfie with this and go like this. It's just amazing. Now we're waking up. Now we're really warming up for the most tough questions that are coming up. So clearly, nitric oxide, the molecule of the year in 1990. This is what made a huge difference in neonatology. We just don't see the kids going on ECMO and receiving all kinds of therapies that were most of them futile. So this you may or may not need to answer this. It's up to you. Newborns who do not demonstrate a difference in the preductal or to postductal values for SpO2 and PaO2 do not have PPHN. True or false? This is like going to the casino and play black or, is it red or white? I don't play. Suspense. He couldn't make it any slower, and he has to go like 94% false. Absolutely correct. So, what is the reason for that? I'll tell you what the reason is. Because some of the babies shunt at the atrial level. Once they start shunting at the atrial level, all these differences between pre and postductal disappear because the mixing takes place in the upper chamber, so by the time they reach the aorta, there is no more differential in saturations. This is a clinical syndrome. Just saying PPHN is not a diagnosis. There's always a last name for the first name, PPHN, and there are two major pathophysiological principles. One is maladaptation, the other one is maldevelopment of the pulmonary vasculature. This is a little bit more than you want to know about PPHN. But primarily, all these babies have decreased pulmonary blood flow, and they shunt right to left at the atrial or ductal level, and that promotes significant acidosis and hypoxemia. So the associated disorders, maladaptation, normal pulmonary structure, increased pulmonary vascular resistance, and all the culprits are listed there. Maldevelopment, this is a different type of population. These are the kids we deal with in the NICU with congenital diaphragmatic hernia, intrauterine hypoxia, alveolar capillary dysplasia, fetal ductus arteriosus closure. These are really the stuff for the neonatologist. They present in the first a few hours of life. They tend to get worse. The X-ray could be one of meconium aspiration, or could be an X-ray that's totally black, meaning there is no or very little pulmonary blood flow, so the lungs are being shunted, so kids cannot really establish a source of gas exchange. The echocardiography is the diagnostic, and oftentimes it's really difficult to differentiate these babies from a baby with congenital heart disease, especially transposition of the great arteries or pulmonary atresia without a ductus or pulmonary atresia with intact septum or tricuspid atresia. So the management is symptomatic basically, and now with INO, basically we make a huge difference for these babies. And for the small number of kids who do not respond, they still go on ECMO, and instead of 40 babies going on ECMO every year, at some of the local institutions, there may be 1 or 2 babies every couple of years going on ECMO these days. Okay, moving right along. This is 5 minutes, but actually I know that we started late, so it's going to be 6 minutes instead. A neonate born at 38 weeks gestation has tachypnea, expiratory granting nasal flaring, subcostal retraction, cyanosis shortly after birth. The mother had ruptured membranes 36 hours prior to vaginal delivery and has developed urine, tenderness, and fever, the mother. Of the following, the most likely chest radiographic finding in this infant is mediastinal displacement, diffuse reticulogranular pattern, lung overinflation with coarse densities, prominent prehilar stricken, fine curvilinear lucencies. This is a tricky one. I expect a 50-50 draw on this one. 3C. This audience is smarter than I thought. Yeah, that's absolutely right. But this is a caveat. A lot of people last year that I don't want to talk about, they chose diffuse reticulogranular pattern, and they were not wrong actually. But you are more right than they were. That's why you're here this year. We didn't let those back. You cannot, as a radiologist, neonatologist, pediatrician, if I show you a film of respiratory distress syndrome, like you saw before, and a film of a kid with neonatal pneumonia, the answer should be you cannot distinguish them, right? You cannot distinguish RDS from pneumonia. This one is a little bit more, yeah, I know what this is. But if you're going to see a different type of film in pneumonia, is lung hyperinflation, some coarse infiltrates, and you can see on this one that there may be a couple of areas. I don't know if you noticed there and there that may be starting to look like abscesses and things like that. And so this is a typical kid with neonatal pneumonia. The most appropriate initial combination of antibiotics to treat neonatal pneumonia is A, B, C, D, or E. You should remember this from yesterday. I expected 97.9 or more. I've been doing this for a while. So, congratulations to the 97% of you. And there's something that the 3% who chose Vanco and gentamicin, it's okay, don't worry about it. But it's 97% of you who chose the right one. Still, with all the organisms that we deal with, AMP and GEN continue to be the drugs, the combination of choice. In some places, people are using a lot more cefotaxime, and that should not be the case. We're creating a lot of antibiotic pressure, which leads to bug resistance. And then we have to resort to, the bigger guns. So it's still AMP and GEN for most of the newborns in the first couple of days of life. It's more than plenty coverage. So neonatal pneumonia, I'm going to go through this very quickly because Dr. Sabella will expand on this. It's more common than people think, especially in stillborns and babies who die in the NICU, 20 to 60% in autopsy specimens. The agents are acquired in utero, perinatally or postnatally. The transmission could be transplacental aspiration of contaminated amniotic fluid, hematogen spread, which is the most likely source, inhalation, less common, and the risk factors are listed, and obviously PPROM and fever, chorioamnionitis, and GBS colonization are the most common ones. This is more common in preterm babies than in full-term babies. There's a bunch of organisms that can cause this. Dr. Sabella will touch upon some of those. What we still see is a lot of some GBS, and we see a lot of kids in whom we cannot make a diagnosis. There's a surge of gram-negative organisms because of the expanded use of ampicillin and penicillin in lieu of, because of the GBS colonization treatment programs, that there's a significant pressure. So GBS we don't see anymore. GBS is now 0.34 per 1,000. We used to see about 6 to 7% per 1,000. We don't see that anymore. But now we see occasionally kids with E. coli and gram-negative organisms. They present typically with the same sort of symptoms as we mentioned before, and usually they're born sick or they become sick very quickly after birth, and they could be really, really sick. And actually some of these babies still die unless they end up on ECMO and still die. And the late onset is mostly gram-negative organisms in the NICU. Rarely we see fungal infection anymore, and usually when it's a late infection, they present with systemic symptoms more than respiratory distress, and oftentimes they do have meningitis as well. We talked about the red light. We talked about the radiographic findings, and you can't really tell the organism by looking at a chest X-ray, but when you see cavitation, you have to think, anaerobes, or you have to think staph, which we have seen in the past. The management is supportive, basically antibiotics and respiratory distress. This is a typical X-ray of a preemie with pneumonia. You can see on the left-hand side, this kid had Staph aureus pneumonia, and you can see that there's centralized intestinal loops. This kid was really, really sick. This was the daughter of a colleague of mine who's now 15, and she's doing beautifully. All right, we're going to do one more. I don't want to delay your course too much. It's been a long day for you guys. After successful intubation and manual ventilation of a 26-week gestation infant at delivery, the infant is pink and vital signs are stable. Color abruptly turns blue. Breath sounds are diminished on the right, normal on the left, and heart rate rapidly falls. The colorimetric carbon dioxide detector continues to display cyclical color changes. Of the following, which intervention is most likely to resolve these findings? IV bolus of normal saline, endotracheal administration of epinephrine, needle thoracotomy, reintubation, surfactant therapy. Beautiful. Beautiful, beautiful. This is a typical baby that we see in the NICU occasionally, who's on a ventilator, horrible looking lungs, and the nurse calls you because the kid started to have horrible saturations and the heart rate drops and things become chaotic, and you can see a massive tension pneumothorax, and basically the treatment for that is needle aspiration, and then some of the kids require a chest tube. There are other typical air leaks that we see in the NICU. Pneumothoraces and pneumomyostinosis are things that you may see actually in the newborn nursery, and we talked about that a little bit. Less common air leaks include PIE, subcutaneous emphysema, pneumoperitoneum, and pneumopericardium. These are usually related to aggressive ventilation, but most of the times are related to the background illness that led the baby to need really respiratory support. Pneumothoraces could be asymptomatic, as I mentioned before. Some of them may actually worsen over the course of time. And one thing that you should not do when you go back to your respective institutions, and I know a lot of pediatricians are doing nursery and special care nurseries, putting these babies on 100% oxygen doesn't really help anything at all. That's another old tale that we used to be taught in med school. When you put a kid with a spontaneous pneumothorax on 100% oxygen, yeah, it's going to go away. But the fact is that it's going to go away anyways. It doesn't matter. If you put them on 100% oxygen, you are oxidizing them. The oxidative stress is horrible for a lot of basically tissues. I'm going to break this to you, but we all die from being oxidized. That's why we're trying to eat more blueberries, strawberries, and all these things they try to sell us, because we try to avoid the two major killers of humankind: oxidation and inflammation, right? So just put these babies on enough oxygen to maintain their saturations, but don't put them on 100%. It actually keeps them in the hospital longer, and it may increase their potential for oxidative stress long term. So not a good idea. Risk factors, as I mentioned before, listed on this slide. You're going to get more slides than the ones that I show you because I shortened this lecture quite a bit. This is the freebie. This is a kid with pulmonary interstitial emphysema, which is a bilateral condition of the preemie baby primarily, with significant barotrauma. A lot of these babies end up dying from pulmonary insufficiency in the first few days of life, and not much you can do for this. This is a baby that you can see in the normal newborn nursery. When you look at a baby like this, don't look at the film on my left. Just look at the film on the right. And if I show you the film, many of you, like many of my colleagues and many of our trainees, would actually say that film is fine. But when you look with more detail, if you look at the right side of the heart, it's almost delineated as if somebody drew it with a pencil. Very sharp borders. There is no mediastinal shift, just sharp borders on the right side. You can see the SVC coming down up there on the, right here, that's the SVC. You can see this sharp border, sort of a dark lung, but you can see some lung markings. When you see that heart delineated like that, that's an anterior pneumothorax. There's a pneumo there. People miss this. So you get a lateral view, which you rarely get in the newborn, and then you're going to see this free air in front of, right below the sternum. So this baby has an anterior pneumothorax, which may or may not need treatment because it's not a tension pneumo. With that, I'm going to stop because Dr. Sabella is approaching me, and I'm really afraid of him. So I wish you the best of luck. Now, seriously, if I had to take my boards again, which would be the 10th time that I'm trying to pass him, I would actually take this course because it is clearly one of the best courses, and I learn a lot when I show up, and usually I catch endocrine, which I hate, but I'm going to go home and actually read up on a few things because my boards are coming up in 3 weeks, so I should go home and study. All right, guys, good luck and thank you for your attention.